Welcome to The Deep Dive. We're your way to quickly get up to speed on, well, complex stuff that shapes our world. Today, we're diving into something really fascinating, a concept that, honestly, changes how you think about stress and trauma. It's called the window of tolerance. Our mission really is to unpack how severe emotional trauma affects us, long term, and how this one model offers a surprisingly clear path to understanding and maybe even emotional regulation.
Yeah, and we're basing this deep dive on a really insightful 2011 paper. It's by Corrigan, Fisher, and Nutt. It really focuses in on the psychopharmacology side of the window of tolerance, specifically looking at how the model applies to severe emotional trauma.
Which includes things like childhood abuse.
Exactly. Profound stuff. Childhood abuse, adult trauma, the kind that leads to PTSD, chronic depression, anxiety disorders, the heavy hitters.
And what's really eye-opening for you, listening, is how this whole idea can offer a totally new lens on behaviors we usually see as, well, dysfunctional. It kind of reframes them, doesn't it? It shows them as these deep-seated, maybe misguided attempts to self-regulate.
Precisely. It changes how we think about our own reactions, or maybe others' reactions. And crucially, it points towards actual pathways to healing, not just symptom management.
Okay, so we've kind of hinted at how this reframes things, but let's back up. Let's lay that foundation. What exactly is this window of tolerance? Why is it so important for understanding trauma?
Okay, so the window of tolerance, Siegel first talked about it, then Ogden and others built on. It's basically a model, a way to understand those often really rapid, sometimes confusing ups and downs in our emotional and physical states after severe trauma. Think of it like an optimal zone of arousal, a kind of mental sweet spot.
Okay.
And inside this window, you can handle your emotions. They feel tolerable. You can think straight, integrate new information, learn. You feel, grounded.
Right.
Now, this window sits between two extremes. One is high alert, sympathetic hyperarousal. The other is shut down parasympathetic hyperarousal.
And you mentioned it's not something we can, measure with an instrument yet.
Not directly, no. It's a clinical model. But even without that direct measurement, it makes these incredibly complex trauma disorders, especially ones from childhood abuse, much more understandable.
That's a really helpful image, finding that sweet spot where you're actually present, able to process. So if that's the zone we want to be in, the big question is, how does trauma push us out of it? What happens?
Well, it comes down to our body's automatic responses. The autonomic nervous system, the ANS. When you face a threat, the ANS kicks in immediately. It triggers those deep survival responses. On one side, you get sympathetic hyperarousal. That's your fight, flight, or even submission mode. Body ready for action.
Instantly.
Instantly. And on the other side, there's this deep protective shutdown. That's parasympathetic hyperarousal, often called the freeze response. These are ancient mechanisms purely designed for survival.
Okay, so that's the immediate reaction, survival mode. But the paper points out, and this seems key, the real struggle often comes after the danger is gone, right?
Exactly right. That's the crux of it. The paper highlights that even when the threat is over, many trauma survivors continue to suffer from autonomic sensitivity. Their nervous system stays, well, jumpy, highly reactive. It gets triggered by stimuli, sometimes things directly related to the trauma, sometimes things that are only vaguely reminiscent.
So anything can set it off.
Pretty much. And this leads to what the source calls a bewildering array of symptoms. Intense emotions, fear, shame, rage popping up, seemingly out of nowhere, but also sometimes a deep numbing of feelings, of body sensations. The whole stress response system just stays switched on high.
And people develop these really negative beliefs about themselves, too.
Yes. Painful negative self-beliefs. And patients often report just finding it incredibly hard to tolerate any strong emotion or physical sensation without getting completely overwhelmed.
And then struggling to come back down.
Struggling hugely to recover from that intense activation or from periods of deep depression. It's exhausting.
The source talks a lot about the body's role here, too, these really strong somatic responses, where the body itself feels frozen or collapsed, or maybe driven and agitated, and action feels impossible. Or it's just impulsive.
Yes, exactly. The body remembers. It holds that tension, that pattern. And it's fascinating and also quite scary how even cues that aren't objectively threatening can trigger these deep fight, flight, or even submission responses.
Because the system is just stuck on high alert.
It's operating outside that window of tolerance.
Okay.
It's in a state of profound emotional and autonomic dysregulation. It's involuntary, deeply wired. So on one side, you have that sympathetic dominant hyperarousal. Think Emotionally flooded, super reactive, impulsive maybe, hypervigilant, always scanning for danger.
Feeling fear, anger.
Intense fear, anger, you might get intrusive images, overwhelming feelings flooding back, racing thoughts, flashbacks, nightmares, sometimes even risky behaviors like an internal alarm bell just won't shut off.
Wow. And the other side, the hyperarousal.
Parasympathetic dominant hyperarousal. That looks very different. Maybe a really flat affect, numb, feeling empty or dead inside. Cognitively, you might feel dissociated, like you're not really there, can't think clearly.
Physically feeling collapsed.
Physically collapsed, yeah.
Yeah.
Defensive response is disabled. It leads to these profound feelings of helplessness, hopelessness. The whole system just shuts down, powering off.
And you mentioned a specific freeze state earlier. A lot of people might recognize that feeling, being scared stiff. How does that fit in? Is it one or the other or something different?
It's actually a bit different and particularly difficult. The freeze response happens when both the sympathetic and parasympathetic systems activate at the same time.
Both. How does that work?
It creates this state of, well, mute, terrified, frozen defense. Inside, you have incredibly high arousal, the sympathetic system screaming danger, but externally you're physically immobile because the parasympathetic system is hitting the brakes.
Like being trapped. It's exactly. Trapped in your own body, like being scared stiff, or even catatonic in extreme cases. And the paper notes this state is strongly linked to really severe long-term issues, like chronic depression and anxiety years down the line. High alarm plus total paralysis. It's debilitating.
Okay, this is painting a really clear picture of being outside that window. So let's circle back to those behaviors we talked about earlier. Things like self-harm, substance abuse. Does this model suggest they're actually attempts to cope with being in those extreme states, to get back in the window somehow?
That's precisely the reframe. It changes everything about how we might view those behaviors. The paper argues that what we often label as dysfunctional self-harm using substances, whether it's stimulants like cocaine or amphetamines to, activate dopamine and maybe feel something or break through numbness, or using depressants like alcohol or cannabis to try and calm down that hyperarousal.
Or even compulsive activities. Yeah. They're seen as these kind of desperate primal efforts to manage an autonomic nervous system that's just constantly getting thrown into hyperarousal. It's not about inherent badness. It's the body trying, often in really maladaptive ways, to reduce distress, to regulate those overwhelming high or low states. Wow. The source gives some pretty intense examples, doesn't it? Like suicide planning being used sometimes to activate arousal if someone's numb, or deactivated if they're overwhelmed.
Exactly. It sounds paradoxical, but from the body's perspective, it's an attempt to shift the state.
And even things like repetitive washing or cleaning.
Yeah.
Trying to manage that inner turmoil.
Yes, those can be attempts to avoid that intense internal dysphoria. The body is just searching for any strategy to cope, even if it doesn't really work long-term or has negative consequences. And this leads to what the paper calls a biphasic roller coaster of experience. There's actually a figure in the paper showing this. It's this rapid swinging between extremes, hyperarousal, hyperarousal, and these frantic efforts to regulate, often using those dysfunctional behaviors, which just creates more chaos.
Creates total chaos.
Yeah.
It's a deeply disturbing experience. The source gives this example. Imagine someone eats for comfort to soothe flashback terror. But then the eating leads to intense shame, maybe suicidal thoughts.
Okay.
So they isolate themselves. But the isolation makes the intrusive memories worse, leading to maybe rage. So they try to numb the rage with alcohol. Then the alcohol withdrawal causes high arousal, which triggers more flashbacks. And the cycle just keeps going. Every attempt to regulate ends up fueling the next crisis. It's a relentless, distressing loop.
That's a really powerful and frankly bleak picture of being stuck. Let's zoom in on the brain now. What's actually going on neurobiologically? What parts of the brain are involved in keeping people stuck in this dysregulation?
Right. So it's not just in the mind, it's deeply physical. Several brain areas are key. First, there's the midbrain periaqueductal gray, the PEG. Yeah, it's a really crucial structure. It's basically wired to control our primal defense responses. Different parts of it handle fight, flight versus freeze. Then you have our ascending dopamine tracts. Think mesocortical, nigrostriatal, mesolimbic systems. These are heavily involved in longer-term mood and arousal.
Dopamine, so that's related to reward and motivation.
Exactly. And an imbalance in these dopamine systems might actually drive those rapid, wild swings between hyperarousal we just talked about. It's interesting, actually, animal models used to study depression often use things like pain, isolation, social defeat, basically traumatic experiences, to deliberately cause changes in these dopamine systems.
That makes sense. Any other key areas?
And then there's the prefrontal cortex, the PFC, our brain's CEO, you could say. Specifically, the orbitomedial part has connections that help regulate core emotions and those defense responses. Different bits of the PFC control sympathetic versus parasympathetic activity. The ventromedial PFC, for instance, is linked to the vagal brake. That's our ability to calm ourselves down. If these PFC areas are offline or dysregulated,
then our ability to self-regulate is shot.
pretty much, yeah, severely compromised.
So that's the functional side. Are there actual structural changes in the brain, too? Does trauma physically change the brain's structure?
Well, the evidence is still emerging, but yes, there are preliminary findings. Some studies show patients with complex trauma and dissociative disorders have smaller hippocampal volumes.
The hippocampus, that's important for memory, right?
Memory and context, yes. And importantly, the size reduction seems to correlate with how severe the symptoms are and how early the trauma occurred. It suggests a real physical impact. The source also mentions reduced activity in the thalamus in trauma subjects, although exactly how that links to arousal needs more research. But the point is, trauma isn't just psychological. It can leave a physical mark on the brain. And building on that brain connection, the paper talks about how repeated fight or flight responses that get blocked, like you can't fight, you can't flee, can morph over time into chronic low mood. Those feelings, those thoughts of hopelessness, helplessness, worthlessness, they start as maybe short-term, biologically driven survival states, accompanied by that parasympathetic shutdown.
But then they get stuck.
You get stuck. They become chronic. They feel like the absolute truth, inescapable.
So it's not just thinking negatively. Feelings like hopelessness or worthlessness can actually be physiological survival responses that are just stuck on repeat. That's a huge shift in perspective.
It really is. Take helplessness. Physiologically, it involves losing energy, muscle tone, feeling collapsed, thinking slows down. It promotes resignation, conserving energy. It's the body's way of saying, okay, fighting isn't working, escape isn't working, let's just shut down to survive. So from this perspective, chronic depression symptoms, that feeling of hopelessness, it reflects those incomplete or blocked fight responses, automatically followed by this kind of total submission response from the parasympathetic system.
And the energy conservation aspect lets people stay in that state for a long time.
Right. And the subjective experience is chronic depression, hopelessness, worthlessness. But understanding the biological roots, it changes how we approach it. The source also brings in this idea of the Distress Dipole model. Imagine being trapped between opposites, feeling completely helpless and incredibly agitated or enraged at the same time.
That sounds awful.
It is. Or feeling numb and hypervigilant simultaneously. These aren't just random feelings. They are opposing survival states that are somehow coexisting chronically. The paper gives examples of matching pairs of negative thoughts like feeling worthless, which is hyperarousal, while also feeling constantly on edge, which is hyperarousal. This creates what they call a dynamic dysphoric tension.
A tension,
Yeah.
like being pulled in two directions.
Exactly, pulled apart. And it basically traps you, making it almost impossible to access any positive feelings, any sense of calm or safety.
Okay, understanding all this, the neurobiology, the cycles, the dipole, it's incredibly insightful, but also heavy. So where's the hope? What does this mean for treatment? How do we actually help people get back into their window of tolerance? This is where the rubber meets the road, right?
Absolutely. And the good news is the window of tolerance model isn't just descriptive, it's prescriptive. It points the way for treatment. The core goal becomes regulating that autonomic arousal, helping patients get to a place where they can, as the paper puts it, both think and feel.
Getting back into that sweet spot.
Getting back into that sweet spot. And what we see is, as people develop more capacity to self-regulate their arousal, their symptoms often decrease, sometimes dramatically. And this makes them much more able to actually engage with and benefit from standard trauma therapies.
So regulation first, then processing.
Often, yes, or at least regulation alongside processing.
Yeah.
Now, pharmacologically, the paper mentions that certain meds like quetiapine and olanzapine, which are atypical antipsychotics, might actually help widen the window of tolerance, make it bit bigger, a bit more resilient.
Yeah, okay, that's interesting.
But there's a big caution, too. Antidepressants need really careful handling. Sometimes they can actually ramp up anxiety and arousal. This could push someone into a hyperaroused state. And the paper notes this could even provide the energy for a suicide attempt if someone was previously too shut down, or could cause really rapid, distressing swings between the extremes. So it's definitely not a simple fix. It needs careful monitoring.
Right. So medication can play a role, but it needs care. What about non-drug approaches? What
hmm
does the source suggest for actually building that self-regulation capacity, helping people find their window again themselves?
This is crucial. The paper really emphasizes patient education first,
Yeah.
just helping people understand what is happening in their bodies, these physiological states, the hyperarousal, and how these states are actually perpetuating the symptoms. That knowledge itself can be empowering.
Demystifying it.
Exactly. Taking away some of the fear and shame. Then a huge part is learning to substitute more effective, less harmful behaviors to manage these autonomic states. So for both hyper and hyperarousal, things like mindful curiosity, just noticing what's happening without judgment, and that psychoeducation we mentioned, are seen as regulating in themselves.
Okay. And for specific states, if someone's feeling really agitated, hyper-aroused.
For high arousal, the focus is on soothing strategies. Things like controlled breathing, gentle stretching, maybe more vigorous exercise if appropriate, yoga, or any physical activity that requires focus can help channel that energy and calm the system down.
And for the other end, for hyperarousal, feeling numb or collapsed.
For low arousal, the aim is gentle activation. Gentle movement, maybe listening to engaging music, humor even, or anything that increases cortical activity, basically, getting the thinking brain gently back online. It's about consciously noticing the state and using targeted strategies to nudge the nervous system back towards that window of tolerance, towards balance.
Wow, what a journey through this model. It's been incredibly illuminating, really understanding the window of tolerance, the neurobiology behind it. It genuinely transforms how you see trauma responses. And even those behaviors we used to just label as dysfunctional or self-destructive, now you can see them differently, can't you? As these deep, ingrained, maybe not helpful, but understandable attempts to survive. It really does shift the whole narrative away from judgment.
It absolutely does. And maybe if we connect this to the bigger picture, thinking beyond just the individual, it raises a really important question, doesn't it? How does recognizing that these are often involuntary physiological and cognitive responses, things designed for immediate survival, how does that empower us? How does it help us approach chronic conditions like depression and anxiety with maybe more compassion?
And more targeted interventions, too.
And more targeted interventions, exactly. Knowing that often these conditions might be the long-term consequence of a nervous system just stuck in a survival loop, rather than some kind of fundamental character flaw.
That is a really profound thought to end on. Something for all of us, for you listening, to really consider. How might this concept apply to your own life, your own understanding of stress, your emotional reactions, maybe even the behaviors of people around you? Keep asking those questions. Keep exploring. And keep diving into this fascinating connection between our minds and our bodies.